From looking at these 14 systems, we actually found in 13 out of the 14 that the outcomes for older people were worse than in the non-integrated systems, which of course was a bit of a kind of counterintuitive, not quite what we expected to find, and something we actually needed to understand why. There was one council and health area where we actually saw, after a period of time, about 7 years, suddenly the system was beginning to improve and deliver better outcomes. And that was in Torbay, so one of the smallest English councils, so it has some advantages in that. Very interestingly, it was the common model in England was that the health service ended up being the kind of senior partner. They ended up running the integrated model. So it was contended to be, and that was certainly the case in Torbay. It was the chief executive of the Primary Care Trust who actually became the director of adult social care in this model. One of the things, though, that Torbay Council had done was try to define in their agreement the outcomes they wanted from this model. And you could say that might have been one of the things they got better than some of the other joint integrations. Probably above everything else, I would say, which of course is always the sad story for social care and health, there was a charismatic leader who had a very clear vision of how he wanted to take forward these joint services, and he did a lot with his staff to build those joint sense of outcomes. And the outcomes that were particularly defined were outcomes that focused on lower, exactly the things you've been talking about, lower lengths in hospital, lower readmissions from people who've been in hospital being readmitted, and reduction in admissions to residential and nursing homes. One of the very interesting phenomena of Torbay is the significant reduction in admissions to nursing care that they've achieved over the last decade. But when you look at that again, you see a whole set of things that are in place. For example, a much stronger investment in community nursing than you would expect to see, than you would see in other parts of England. So a real investment in community nursing, and that community nursing seeing itself as having a very strong role to play within residential care homes. So many people who are in residential care homes get the kind of quality of nursing, maybe even better than they would have got if they'd stayed in their own home. So a kind of particular feature that maybe people, you have to look behind all the kind of big picture to see that. And I think an interesting point, certainly when I was a director of adult social care, I used to constantly be saying to my primary care trust partners that I needed a greater investment in community nursing in order to sustain people living longer in their own homes, was the issue there. And I think Torbay has demonstrated that. So I suppose the big issue, the big learning in England is that it took time for the integration to happen. There are the tensions that exist, and I think the cultural tensions between health and social care are very strong. They're very different disciplines, they're very different mindsets. So it takes quite a while to get the workforce to encourage people to kind of build the joint system. And the strength of the one system that everybody holds up as having worked was where it had a very clear vision about improved outcomes that the total system was going to deliver. I'll come back to that. So in Torbay, we did see lower emergency admissions, lower hospital bed days, lower admissions to residential care, though from a very high base, significantly lower admissions to nursing care. There was at the time of this introduction a higher use of domiciliary care, In fact, very interestingly, I'm doing some work for the Local Government Association in England at present, which Torbay is a part of a piece of work. And Torbay's current challenge is to reduce its use of domiciliary care. They found, and I'll come on to this in a bit, that they were giving people what I call dollops of domiciliary care, almost as a kind of alternative to kind of getting the health and social care bit sorted. It was almost like domiciliary care on prescription, a bit like you might have a statin. You have a statin, have a bit of domiciliary care. And I'll come on to the evidence that actually, I think we now know that that is bad for you. The domiciliary care is bad for you. I'll come on to that in a second, just to explore. It's a kind of piece of work I've done a lot of exploring of in the last couple of years, which is this whole issue of when does an assessment take place, and a policy that is both in English and in Welsh documentation, but not clearly followed, is that no one should actually be admitted to a residential care bed from a hospital bed. And a number of authorities have that policy. You can see, this is data from Wales, which actually shows that the performance in admission to residential care from Welsh authorities direct from a hospital bed varies considerably. And those places that have those higher admissions are very, very clear they need to look at that and work on that. Most of the major studies suggest across the United Kingdom that about 20% of older people who end up in residential care, their admission could have been avoided. The work I have done directly in councils in Bridgend, in Warwickshire, in Westminster, has all, and currently in the London Borough of Hackney, would actually put that figure at a higher figure, put that figure somewhere near a third. So the kind of general evidence would see, well, where has integration worked? And I think the evidence in England would suggest that creating joint teams in particular areas with clear focus has delivered better outcomes for people. There's some excellent examples across England of where the intermediate care service, the out-of-hospital team that is working to support patient discharge, when they're a joint team, can actually deliver better outcomes. The savings actually come in kind of hundreds of thousands from the integration. The bigger savings, the millions, come from the outcomes achieved. So just by putting the teams together, you may save the cost of a couple of managers. That's not where your focus should be. Your focus should be on, well, is this system delivering better outcomes? And I can give you an example. So I've already touched on, well, what can we learn and what might we learn in Scotland that hasn't worked? It certainly has not worked if it is entirely what I'll call a traditional health-dominated social care model. If health is the dominant partner, if it brings the general risk-averse nature that sits within the health service into the social care setting, you tend to have more cautious interventions, you tend to have more dollops of care, which tend to lead to poorer sets of outcomes. So we recognise these tensions in the system, and actually I was talking, my sister was a district nurse, is now what they're called these days, in charge, matron, responsible for discharge from a large acute hospital. She would argue that actually there's a real help in the fact that we do have tensions in our system, that actually is what makes it work. The ward sister wants to clear the bed, tends to want the patient to continue with the kind of care experience that the hospital's given, whereas the social worker is in there arguing for getting the right kind of set of outcomes to support the discharge, again with hopefully the end in mind of the person remaining at their own home, retaining their independence. And if we haven't got that tension in the system, the risk is we do end up with worse outcomes. That people do get driven more out of their Glamorgan into the nursing homes, into residential care, because at that point in the system, and any assessment might say this person isn't coping. The question is, would they be coping in 3 months' time if they were given a different set of interventions and support? What we really understand prevention to be, and is, excuse my language, but is a dollop of domiciliary care a preventive measure? And I think the evidence is compelling to say it's not. In fact, I think the evidence tells us that once you enter the care system, your need for care accelerates at a very rapid rate. Now, that doesn't mean we shouldn't offer people care, but it does mean where we can and where we ought to be focusing all our early efforts with someone on how to keep them out of the care system. And that includes their health needs. So, and there's of course a secondary question as to whether or not the current health service has really, when we talk about outcomes, have we really defined the kinds of outcomes that we want, given the demography, for healthcare for older people? And take our most common challenge, dementia care. Why is it where the evidence is quite compelling that early diagnosis of dementia and helping people live with dementia can reduce a whole set of later problems? In none of the UK health and social care systems have we got that right yet. It's not, doesn't tend to be the kind of have the health priority, for example, that it ought to have, given its prevalence and its challenge. And part of what I would hope, if we start moving more into integrated models, is actually social care has a lot to bring to the table in terms of things like, where is health in relation to dementia care? Where is health in relation to helping older people manage incontinence? Where is health in terms of its falls prevention strategy? Where is health in relation to stroke recovery? Where is health in relation to foot care and dental care? Because actually those are the areas that we know from well evidence. I'm sure you heard my colleague Professor Kerslake on this subject. I'm sure he's been up here and waxed lyrical. He's done a lot of work which shows these are the health conditions that most influence social care. And yet Andrew's work in England shows that they are not the things that help to which health. See probably the best example in practice of the evolution of an outcome-based model. I'll refer you to the developments that have happened in Wiltshire County Council over the last 2 years, where they have what I call a proper, let me reframe that. They are still developing, but have all the ingredients in place for a proper outcome-based model for social care, where everything is outcome-based. All the social work assessments are assessing people for outcomes. And they primarily assess people for outcomes that will promote the person to be more independent. All contractors are paid for delivering outcomes. In fact, it doesn't quite work like that. They get penalties for not delivering outcomes. Actually, is the way it works. That if you're going for your integration, let's build, and I can show you, I can email you models that you can see. Kate may have more to offer us. I'm focusing on the outcomes of the system, and for social care, I would really urge you to define the outcomes that promote independence. to focus on what we know really works for prevention, those interventions in people's lives that actually will make a difference, which is not a dollar for domiciliary care. And part of that is actually we ought to be demanding, requiring, requesting, pleading actually for some better health care as part of the deal for integration. Thank you.